Good morning, everyone. Okay, today we are in the competition of the student research competition at 2019. We have 7 groups. With each group we have 15 minutes. Each group we have 12 minutes. Okay, 10 minutes for presentation and 2 minutes for the question. Answering the question. Okay. We have staff precaution you for the time 1 minute left or finish the time finish. Okay, we have 7 group. Group 1. Are you ready? Team 1. Okay. For Miss Piyarat Siri Ratnakul, the topic of research is root canal morphology of Mahidol root of permanent maxillary first molar in Thai population, microcompute tomographic analysis. Okay. If you're ready, you can start.
มันฟรีซอยู่วะ
Good morning, everyone. It's my honor to be here and proudly present our research, which is root canal morphology of Mahidol root of permanent maxillary first molar in Thai population microcomputed tomography. We have 5 researchers with our professional advisor from Department Operative Dentistry and Endodontics. Let's move to the introduction. The purpose of endodontic treatment is to prevent and to treat apical parodontititis by eliminating bacteria in root canal. From previous study reported that 1/3 causes of endodontic failure is missing uncleaned canal, especially in MB2 canal in upper first molar. So, the importance of study in root canal morphology is very important to increase the success rate of endodontic treatment. From previous study, there have only 2 studies that study MB2 in Thai population, but none of them use micro-CT to investigate the root canal system. So, the objective of this study is to classify the root canal configuration of Mahidol root according to vertex classification, to investigate the prevalence of second Mahidol root canal, and the last one, to measure the geometric location of second Mahidol root. Let's move to the methodology and data analysis. This research was approved by Ethics Committee. For the sample preparation, extracted maxillary first molar from Thai people which cannot identify the personal information were collected following the inclusion criteria. The teeth with root caries, root resorption, root fracture, or root restoration were excluded from this study. Then the teeth were cut with 2 mm coronally to the CEJ. Then smear layer was removed by soaking with 17% EDTA and 2.5% sodium hypochlorite. Then were scattered by micro-CT. After that, it was 3D reconstructed. We will divide this research into 3 parts following our 3 objectives. Part 1. The pulse chamber of root was investigated under dental operating microscope to investigate the number of orifices. And then 3D image was used to investigate the amount of root canal and apical foramen. For part 2, the 3D image was used to investigate the prevalence of MB2 root canal by using vertex classification, and then we will use all data except type 1 divided by the all specimen. For part 3, the teeth were divided into 2 groups. The first one presents MB2 at pulpal floor level. This group will use to measure the horizontal geometric location according to Goodis's method. Briefly, Goodis's method suggests that drawing the line from MB1 orifice to palatal orifice, then drawing the line from MB2 perpendicular to MB1 palatal line, and then the average distance were mesial distance, palatal distance, and distance between MB orifice. Another group was the teeth absent MB2 at pulpal floor, but had MB2 canal separating from MB1 beneath the pulpal floor level. This group will use to measure the vertical geometric location. For the vertical geometric location, the distance will be calculated by the first lab of cross-sectional image that had 3 orifices at pulpal floor, and another first lab that had 4 root canals. Let's look at the result. MB root canal was classified by vertex classification as approximately type 1 34%, type 2 12%, type T 8%, type 4 and 5 13% equally, type 6 10%, type 7 4%, type 8 0%, and unclassified type as 9%. So, the prevalence of MB2 root canal in Thai population was found at 66.25%. Okay, and for the horizontal geometric location, MB2 orifice was found 0.96 mm mesially and 0.98 palatally to the MB1 orifice, and the distance between MB1 and MB2 orifice was found at 1.48 mm. For the vertical geometric location, in this case, the teeth were absent MB2 at pulpal floor, and then 41% was found that MB2 canal separating from MB1 beneath the pulpal floor. For this group, about 58% was found beneath the pulpal floor level within 1 mm. Another 21% was found more within 0.5 mm deeply, and another 10% was found more 0.5 mm deeply. So, in the summary, almost 90% of them were found within 2 mm from the pulpal floor level. Let's move to the discussion. The prevalence in Thailand of Mahidol root was found 66.25%, which similar to the previous study. The horizontal geometric location of MB2 canal was found that it located mesially and palatally to the MB1 orifice, was similar as the previous study. For the vertical geometric location, we found that within 2 mm, MB2 will separating from MB1 orifice, and then this result also supported by data of in 2015. For the conclusion, MB root canal was classified as vertice classification as shown before. The prevalence of MB2 canal in Thai population was found at 66.25%. The MB2 orifice was found at 42.50%, which location was approximately 1 mm mesially and palatally to MB1 orifice. In case of 41% of absent MB2 at pulpal floor level, 90% of them will found MB2 separating from MB1 within 2 mm beneath the pulpal floor level. So, all of this information will lead us to increase the long-term prognosis of endodontic treatment. By applying all this to the clinical practice to assure that the dentist can locate the exact location of MB2, and then the missing canal of MB2 will decrease. Thank you for your attention.
Very good presentation. Any question? From the floor.
Okay, thank you very much for your nice and clear presentation. Good result. Like you said that in the please move back one slide. Move back one slide. You said that like around 40% that MB2 orifice didn't show at the pulpal floor, right? However, I wondering about the pulpal floor that you use as a reference because it's a clinical landmark, right? But from CBCT, no? How did micro CT? How did you like set up the level that this is the pulpal floor level? Because the pulpal floor is not like a flat, right? Not completely flat.
As I said in the methodology, we will define the pulpal floor level by the first lab that had 3 orifices. 3 orifices.
So it's not it corresponds to the pulpal floor in clinical situation, right?
But by micro CT, it cannot definite the pulpal floor like in clinical. So we will define the pulpal floor level by the first lab that has obviously 3 orifices that has the oval shape.
Okay, and the 3 orifices is MB, BB, and palatal.
Yes.
Thank you.
Any question? I think it should be associated with a genetic factor, right?
Yes.
Did you compare with any other racial population like Caucasian, Negroid? Is it different?
It's different because from the literature review, we found many research that study MB2 in many races, and we found many prevalence of MB2 is different prevalence in different races as shown in the map. It's the world one map shown depend on any country.
This means you should be more cautious to do the patient in Korea or right?
I think yes.
other question?
Okay. So our research is very important to increase the clinical awareness for the dentist
Yeah.
to locate the exactly location of MV2, especially in Thai population.
Sure, 100% is Thai population.
Yes.
Or Thai Chinese? I'm not sure. It looks like
Definitely less.
Okay, thank you very much, Dr. Piyarat. Okay, thank you. The
Thank
next.
you.
Okay. The next team is Miss Natida Suvarnapam. Okay, for the topic of quality of root canal calculation using 9 tiles. Sorry, I'm not English. 9 tiles in undergraduate without previous hand fine skill in molar.
เปิดแล้วรอแป๊บนึง
Good morning, ladies and gentlemen. My name is Nakira Suvarnapam. I am a fifth-year dental student, and I would like to present our project in a topic of quality of root canal preparation using nighttime rotary in undergraduates without previous advanced skills in molar. And these are the investigators and work lines. Now, let me introduce you a little bit of endodontic treatment. The aim for endodontic treatment is to prevent and to eliminate the medical periodontitis by reducing the bacteria. And the reductions of bacteria can be achieved by the mechanical instrumentations and the chemical methods. But there are studies show that the mechanical instrumentation is the most effective way to eliminate the bacteria. For the mechanical instrumentation, stainless steel hand file have been widely used in this system. But there are limitations, including high rigidity and low flexibilities, which cause us complications. As you can see, it will be presents at left, stiff, or stiff preparation, as shown in these pictures. According to the shortcoming of the stainless steel hand file, the rotary nighttime file was then developed. And this file has a shape memory effect and a high flexibility to curve along the root canal during the root canal preparations, which will lead to the less complication. However, the rotary nighttime is widely used in endodontic treatment. We still teach to use the stainless steel hand file in all undergraduate students. As you can see, these are the radiographs of root canal preparation performed by undergraduate students. You can see that the complications occur particularly in the molars. So, therefore, the endodontic divisions would like to introduce the nighttime rotary to undergraduate programs by adding the root canal preparation using nighttime rotary. But we still have inadequate information to arrange a proper curriculum. So this leads to the objective of our study. The objective of our study is to evaluate the effects of hand instrumentations experienced in molar on the quality of root canal preparations using rotary instrumentations before near dental students. And let's move to the materials and methods. Our study was ethically approved by the ethics committees. For the student allocation, 184 near dental students were ranked according to their MI score. And then they were allocated into two groups, the inexperienced group and experienced group by systematic sampling. And for the two that we used in our study, they had to be selected according to these following criteria. Briefly, they had to be a mandibular molar, and with control length, canal curvatures, and number of canals. For the canal preparation, the inexperienced group was asked are to perform a canal preparation in lower molar by using nitrile rotary, which was the wave 1 goal. While the experienced group was asked to perform a canal preparation in upper molar by hand 5 before rotary instrumentations in lower molar. And the quality of canal preparations was then evaluated from the radiographs by recording the canal length and the presence of ledge, zip, deviation, apical perforation, stiff perforation, and instrument fracture. For the radiographs evaluation, 2 evaluators were tested for the intra-radar reliability with a kappa coefficient equal to 0.91, which made the excellent reliability. The data analysis were completed by SPSS program using high-square tests. And now is the result of our study. The left column is the errors occurred in experienced groups, and the right column is from the experienced groups. Now, the more frequently procedural errors that occurred in this study were uncontrolled working length and the apical perforation. Now, for the uncontrolled working length, we can see that it occurred about 26% from the inexperienced groups and about 23% from the experienced groups. Apical perforation was found about 18 or 19% from both groups, and they were not statically different between 2 groups. And now for the 2 things that did not happen in this study, there were stiff perforation and instrument fracture. And for the total errors from the both groups, there were happened about 32%, which have no statically different. And now for a discussion for the uncontrolled working length and apical perforation. In this study, the uncontrolled working length can be divided into 2 groups, the shorter than the working length and the longer than the working length. For the shorter than the working length, it may occur because of the canal blockage. And more derivatives can be created from the rotary fly, along with the inadequate irrigations and inefficient irrigants, because in our laboratory we use only water to irrigate the canal. And these 3 factors can result in canal blockage that consequently becomes the shorter than the working length. And for the longer than the working length, it's because of the procedural. Because the working length determinations in our laboratories is only for the radiographic evidence. So the working length in the lab may not be the exact the apical reference point may not be the exact minor apical constriction. So this would lead to the longer than the working length. And moreover, the rotary fly has screwing effects that which the fly can easily slip into the canal if the students don't have the proper hand rest. And now for stiff perforation and instrument fractures. For stiff perforation, there are studies prove that the rotary instrumentations have a high flexibility and centering abilities. In case of instrument fractures, in this study, our teeth that we selected was low to moderate curves, and moreover, the reciprocating motions of the wave 1 growth have been reported as it is low risk of instrument fractures. For the results that the reason that 2 groups have no significantly different is maybe because of the hand skill in one upper molar may not be enough to have an impact on quality of root canal preparations in lower molar by using nitrile rotary. So we can conclude that the experience of hand instrumentations in one maxillary molar does not affect the quality of rotary instrumentations in medulla molar performed by fully dental students. The benefits of this study is to improving analytic laboratory curriculum. And for the acknowledgement, we would like to thank 4th-year dental students for attending our study and staff from Simulation Lab for their kindness. Thank you for your attention, and that's really all for the presentation.
that you said that your result is improve the curriculum.
Yeah.
So how to improve the curriculum?
Well, first now you can see that all laboratories separated the student into two groups with like the first one do the rotary first and then the other do the hand first because the equipment is limited. So it's proof that this kind of arrangement does not bias for the students. And for the second, in addition to the improving the curriculum, our study showed that errors from rotary nighttime 5 was created. What was happened? So the teachers can be reminding students to be more cautious when they perform a root canal preparation, like for have a proper hand rest and for the working length determinations and for to have a proper coronal reference point, and moreover reminding about them to have enough irrigation during canal preparation to prevent a canal blockage.
Thank you. I have a question because your project is so big, no? Ran in like a 100 dental students, right?
Yeah.
So the most important thing is how to control or how to calibrate these students using the rotary nighttime in the same way, in the same step, as well as the instructors. How did you control?
For the student into group, we ranked in by their high score. So there will be the smart one and the low high score in both groups equally. And for how they use the rotary nighttime, the teachers like the teachers in the laboratory we have.
You use the file exactly the same. I mean, for example, maybe someone using a short stroke, this pen. Someone use like a long stroke, this pen. When using the file.
We were taught to using the file and not to stay there for too much time, so it would cause the every operation. And for the teacher, we have calibrated the teacher for the paper.
Yeah. So you did, right? So you should mention, because you ran experiment on many people, many students. You say that you control it very well, very calibrate. Good, no? So no question, but you didn't mention. Thank you.
Okay, very easy question. What is night time?
The different titanium fly.
And could you let me know the benefit of the night time fly over stainless steel file?
Well, it have more flexibility if you put the stainless steel fly into the canal. If the canal have a curved canal, the stainless steel fly will go straight. But if the nighttime rotary fly has a flexibility, it will curve along the canals. And when you push the button, the foot button, and the rotary works, they will not create a stiff ornament.
And then I will propose not just only for the MI, I will propose for the nighttime funds, rotary funds,
For
that it can be used
yes.
for the root canal treatment.
Yeah, the root canal treatment, we have to do the coronal flare first, but by coronal flare we can use the fly or the rotary fly, but the rotary fly cannot use to perform a coronal flare, but I'm not so sure about this study, but there are still studies show that some company advertise that we can only use one rotary nighttime to prepare a canal.
And how about retreatment, root canal retreatment? It's okay to use this?
Yes, it helps to clean the bacteria out of the root canals, and then we have to fill the materials in
The next team, the next group is the next group is Miss Radasini. Okay. For the topics of mental health status in Thai painful temporomandibular disorder patients.
Hi. Good morning. Hello.
Hi, my name is Nadasini Dalashon Ladanaksagun, and today I'll be presenting about the mental health status in Thai painful temporomandibular disorder patients. And this project could have not been done without the patience and kindness of Ajahn Somsak Maitri Ladanakun and clinical professor Nataya. So, TMD. What is TMD? First of all, we go back to TMJ. TMD is a temporomandibular disorders, or a group of musculoskeletal and neuromuscular conditions that involve the TMJ, the mastication muscles, and all other associated tissues. And it is also a major cause of non-dental pain in the orofacial region. It is found that 40 to 60% of the general population has signs and symptoms of TMD, but however, those symptoms are self-limited, which means they do go away by themselves over time. Nonetheless, 3.6 to 7% of the population has a TMD, which is severe enough to seek treatment. So therefore, really, it is the pain that is by far the most common cause that cause the patient to come into your dental clinic and seek for treatment. People with chronic TMD exhibit greater levels of psychological suffering on average when compared to normal healthy controls. And with psychological dysfunction, it is associated with greater severity and persistence of TMD-related clinical symptoms. And it could be due to cultural differences, and it would be interesting to find if there are any psychological statuses and factors among the Thai TMD population. Because if we ignore or fail to address these psychological factors, it could lead to a major cause of misdiagnosis, over or under medication, excessive diagnostic workup, not to mention the expensive CTs and other lab tests, inappropriate treatments, and the last thing we don't want is the iatrogenic complications. So our objectives are really is one, to compare the TMD pain dysfunction levels between the non-pain and painful TMD patients. And two is to characterize the painful TMD patients through identification of related demographic and psychological factors. First of all, our methods, we have the sample selections, we extracted the data, and of course we did the statistical analysis. And our research was approved by the ethics committees. As for our sample selection, the patients diagnosed with TMD according to the DC-TMD classification from 15 to 60 years of age, and then we excluded incompleted data and charts without TMD diagnosis. And all in all, we have 160 valid records of TMD patients. Then we extracted three parts of the data. First of all, the physical factors, which were jaw pain score and jaw dysfunction scores. Two, demographic information such as age, gender, occupation, and education. And lastly, the psychological factors, which I will explain a little bit more. The psychological factors, the first one we use to assess the general mental health, provided by the Thai Ministry of Public Health. It is called the Thai Mental Health Indicator, which will assess the patients and group them into three classifications of mental health, which is good, fair, or poor, when compared to the general population. And then the Suan stress test assess the stress levels of the patients. And lastly, self-reported anxiety and depression. Then we classified our subjects into two groups, which were painful TMD group and non-pain TMD, according to their primary diagnosis at the time of the examination. And our results were that we found that from our sample population, we have the painful TMD at 64%. Moreover, within that 64%, the proportion of diagnosis within the painful TMD that is the most common was local myalgia at almost 50%. And as for the association between painful TMD and demographics factors, we found no statistical significance between age, gender, education, nor occupation in painful Thai TMD patients. As for psychological factors, we found a significant association between poor mental health status, stress, work disability, and self-reported anxiety, and we found no significant association between painful TMD and depression or familial interference. So really, when it comes down to our results, we found that the prevalence of TMD in our sample population was at 64%, which is really quite high. When compared to the other study conducted in Sweden, they found only 11%. And this could be because that our sample was collected from a tertiary care facility, which means that the one in Sweden, they collected from the general population, which causes this discrepancy. And there could be a biological difference and a genetic evidence that have been difference between Asians and whites due to the gene COMT and POPMRM1T1 gene that causes difference in the pain threshold between the Asians and whites. And there's no surprise that there will be the difference in the jaw pain and jaw dysfunction scores, and it is statistically significant, especially in the painful TMD, which we have a higher scores. It is because that painful TMD patients present higher pain, functional limitation, and disability, and which we have the more attention being focused on the pain can adversely affect the intensity of the pain. And moreover, even though we did not find any statistical evidence that is significant enough to say that our results were significant, but we did find a great proportion of females in our sample that wanted to seek care of TMD, around about 70%, and which we have a higher prevalence in female in both painful and non-pain TMD. And it has also been confirmed by other studies that TMD prevalence is twice more common in female than male. And as for psychological factors, patients with poor mental health is 2.63 times more prone for painful TMD when compared to the patients with good to bad mental health. And this is because of that the severity of TMD has some effects on the quality of life, and especially the states of emotion and sleep quality. And with increased physical symptoms and associated with variables such as somatization, it also could exacerbate the condition of TMD. And patients with stress are 2.75 times more prone for painful TMD, and because the perceived stress is significantly correlated and has been reported by other studies as well. Self-reported work disability has 4.57 times more prone to painful TMD, and there have been cases where they self-reported more severe headaches, fainting, dizzy spells, gastric reflux, and those eventually could really affect how they're going to work and daily lives. And it also affects the patient both psychologically and physically. Patients with anxiety are 1.8 times more prone for painful TMD. And TMD may be the only somatic manifestations of emotional distress, and pain intensity and failure of jaw movement has an important role in the decision to seek care of orofacial complaints. And the relationship between anxiety and painful TMD is bidirectional. And lastly, even though we did not find a significant association between depression and painful TMD, depression has been reported that it may lower the patient's tolerance to physical symptoms, causing them to seek more care is what is presented as a problem of the body. And according to the study, that Asian patients, TMD patients, tend to underreport depression when compared to Caucasians. There were some limitations in our study, such as ours was secondary data, and it is a retrospective study. There may be some uncontrolled exposure. And lastly, the possibility of over-reporting that the patients want the caregivers to recognize and realize the severity of their conditions and wanting to get the treatment immediately. Lastly, as painful TMD patients are characterized by several psychological factors, therefore painful TMD patients cannot be treated effectively without their attention being paid to biological, psychological, and social profiles of the disease. So then, therefore, the biopsychosocial approach is a key to successful treatment. Thank you.
Okay, thank you very much for your lively and active presentation. I love the way you present it. Okay, for my question, you investigate about the mental health of TMD patients, right? And categorize that poor, fair, and good. What is the poor mental health patient? I mean, are they like a psychiatric patient or not?
Not really.
Or just from the evaluation form?
It is a self-reported evaluation form, so what they have really was a list of questions, and that puts them into different situations and let them assess themselves. They have several questions that is appropriate to Thai people, especially some questions were like, ขยะข้างบ้านเหม็นไหม อะไรอย่างเงี้ย does it affect how you live and how you perceive your mental health status? It does not directly ask you, do you have depression? So it is really how they perceive themselves and how they visualize themselves in different situations, and we evaluate the scores from there.
For example, like they think negative rather than positive way.
Yeah.
Thank you.
Yeah, I have a question about the race. In the beginning of the discussion, you said in Swedish, right?
Yeah.
It has like low prevalence. But in the last slide of discussion, or no, is you say in the Caucasian it has.
Oh, okay.
I think it is. Because in here you said that because Sweden is also Caucasian, right?
Yeah. So this is our painful. The Thai painful TMD that we found was 64%, and then the painful TMD Swedish patient was 11%. And if we go back to the last bit here, I said that okay. They compared the overall TMD patients and depression, so that they did not really characterize the patients into non-pain and painful TMD group. That's why the prevalence of depression, they just only compared the TMD, overall TMD and depression. That's why the prevalence is a little bit different.
Yeah. But I think in the Swedish, do you think why it's so low? Only 11%.
Oh, because they randomly selected from the general population, so they went over about like 1,000 people.
You need to mention it when you say the because you just said the prevalence is different because the methodology of that study and your study are different, right?
Yeah, I did mention that our sample was collected from a tertiary.
Sorry.
Yeah.
And one more, you didn't mention about the statistical analysis, but you present in the slide. I think you should mention because other audience will don't know which statistical analysis that you use in your research.
Okay, thank you.
Which one?
We use the univariate logistic regression in order to find the association between the painful TMD and other psychological
parts, and then we have the odds ratio to compare how many times this needs to happen in order for the painful TMD to become prevalent. And also, we just did this simple comparison of looking for the percentage.
Energetic presentation. So you said that TMD painful leads to psychological suffering, right? And you investigate to 160 medical records. Yeah. And could you tell me the drugs used in these patients? There are differences in the analgesics used in these patients.
You mean treatments?
Yeah, like the history of these patients that have been treated for the painful TMD.
Drugs using. We really looked at the first time they came into the clinic, which was really just the primary diagnosis and the chief complaints. So we did really look at how if they have used a drug, because we only collected the sample and we looked at the present illness rather than what happens if they get treated. Yeah. So I'm sorry, I didn't know what they could have been interventions before. They might have been taking drugs to as some analgesics such as ibuprofen before they come into the clinic, and that could of course have changed the diagnosis that could have been categorized them into the non-painful TMD.
I think just like my opinion, that's just maybe one of the factors for your study.
The next group is Miss Sutina. Wow. Okay, Mr. Sutina. Okay, ครับผมคุณสุทินา Okay. ตันทิกุล in the topics of the behavior of stem cells from human exfoliated deciduous teeth on synthetic PLTA bioglass scaffold of bone tissue engineering. Okay, let's start. Mr. Sutina, can you continue?
Good morning, Professor and audience. Today we're going to talk about the research on the topic, the behavior of stem cells from human exfoliated deciduous teeth on synthetic PLTA bioglass scaffold for bone tissue engineering. The research was done by me and Richard Suksan, under supervised by Dr. Raitip Sithanapudamchai and Assistant Professor Tuvipong Aryapisit. Currently, there are various diseases resulting in a bone loss, so the patient would end up needing a bone replacement therapy to regain function and aesthetic. And bone tissue engineering is an interesting choice for that. Bone tissue engineering consists of three components: the scaffold, the stem cells, and the growth factor. And in this study, we are interested in the scaffold. The widespread well-known material nowadays is polylactic co-glycolic acid, or we call it PLGA, which has advantages on controllable bioresorption, compatible to the human tissue, and high toughness, which make it good enough for bone tissue replacement. But being a copolymer of two acids, when it's resolved, the PLGA scaffold would create an acid byproduct. Moreover, it has poor self-affinity and no osteoinductive ability. Another exciting new material is bioglass, or BG. It has osteoconductive, osteoinductive properties, and also the ability to allow the mineralization to occur. However, the use of bioglass is limited due to its low mechanical strength, low biodegradation, and low biocompatibility. So by adding bioglass into PLGA, it may maximize the property of those materials. Moreover, there's still no report on the proper ratio of PLGA bioglass, which yields the most effective composite scaffold. Therefore, our study aims to investigate the biocompatibility of stem cells from human exfoliated deciduous teeth, or we call it CHET, on appropriate PLGA bioglass composite scaffold. And To accomplish that, we designed the experiment into two parts. The first part is the study of undifferentiated shape consists of morphology and proliferations. The second part is the study of the differentiation of shape into osteoblasts consists of alkali phosphatase staining, alkali phosphatase activity, and osteoblast-specific gene expressions. All experiments were done on three different PLGA bioglass ratio, the pure PLGA, 10% bioglass PLGA, 15% bioglass PLGA. The picture shows the actual scaffold used in the experiment followed by the pore size that tend to be larger as increase the percentage of bioglass. The first experiment was study the cell morphology using live and dead double staining kit. The kit composed of two dyes, calcium AM, which stain the live cell in green, and polonium iodide, which stain the dead cell in red. The results were obtained by confocal laser scanning microscope as showing. The white area show the pore within the scaffold, where the dark area are the border of those pores. We found that shape morphology on three different scaffolds showed a similar manner in that on day one, shape were mostly spherical and stained green, which showing that the cells were alive but still attached on the upper layer of the scaffold. On day 4, the cells start to elongate into spindle-shaped cells similar to undifferentiated stem cells and migrate into the deeper layer of the scaffold. On day 7, the cells still in the spindle-shaped cells migrate throughout the depth of the scaffold and greatly proliferate. Next experiment is the measurement of cells proliferation using cell vector glow kit, which measures cells ATP production. The results were analyzed by one-way ANOVA and represented in the graph, when x-axis show the culture time in day and y-axis show the luminescence read by spectrophotometer, which vary directly to the number of cells. The black graph represents checks culture in pure PLGA, the red on 10% bioglass PLGA, and the blue on 15% bioglass PLGA, which will represent in this color for all graphs in the entire experiment. And as you can see, the number of checks on all experiments increased as the day passed. Interestingly, the number of checks on 10% bioglass PLGA is significantly higher than other scaffolds on day 7, 10, and 14. The second part of the experiment is the study on the differentiation of shape into osteoblasts, and the enzyme that we are interested in are alkali phosphatase enzyme, because alkali phosphatase enzyme play a major role on the mineralization of osteoblasts. Beginning with the alkali phosphatase staining, if shape were able to differentiate into osteoblasts, it will produce alkali phosphatase and then stain blue on the scaffold. The result shown in the picture, the scaffold as you can see in the small picture in the upper right corner is the entire stained scaffold, but the bigger picture are the localized area that were mostly stained, and this is shaped on PLGA scaffold. On 10% bioglass PLGA scaffold and 50% bioglass PLGA scaffold. And we found out that shape culture in 10% bioglass PLGA scaffold show the most intensely stained compared to other scaffold on each day. In this experiment, it indicated that shape were able to differentiate into osteoblasts by producing alkali phosphatase enzyme. However, it's only show that shape can differentiate in the scaffold without showing any actual quantitative measurement. Therefore, the investigation on alkali phosphatase activity was done by alkali phosphatase assay kit. The alkali phosphatase activity retrieved from the experiment were then normalized by the total protein from the Bradford assay. Then the graph will construct on each day compared in all scaffolds, where x-axis represent each scaffold and y-axis represent alkali phosphatase activity. The result can be interpreted that from day 1 to day 14, shapes culture in 10% bioglass PLGA scaffold show higher alkali phosphatase activity with significantly different on day 10 and day 14. And for the last experiment is the investigation on osteoblast-specific gene expression using real-time PCR. And the genes that we are interested in are CBFA1 and osteoid genes, which are the genes that expressed in the early stage of development into osteoblast. Then the expression of genes were then normalized by the gap DH as internal control gene into relative expression shown on y-axis, where the x-axis are the culture time in day. We found out that shed culture in 10% glass PLGA express CBFA1 genes and osteoid genes highest on day 14 and higher than other scaffolds. From the result of the experiment, when adding bioglass into PLGA, it expands the pore size and allows the cells with average size of 100 micron migrate and penetrate into the deeper layer of the scaffold, resulting in more cells proliferation, as you can see in the graph, which corresponded to the study of Filipowska et al. In 2014. However, when adding bioglass into the excess amount, it will lead to the decrease of cells numbers. As you can see that shed culture in 15% bioglass are less than those culture in 10% bioglass PLGA scaffold, which can be the result from the toxicity of bioglass according to the explanation of Francesca et al. In 2018. Moreover, by adding bioglass, it exhibits higher alkaline phosphatase activity and gene expression, agree with the result of Jun et al. In 2004, which showing that bioglass has osteoinductive and osteoconductive properties. And according to the previous outcome displayed, it can be concluded that all scaffolds are biocompatible enough for shed to survive, mature, and differentiate into osteoblasts. And by comparing those three, 10% bioglass PLGA is the most optimal composite scaffold. Therefore, 10% bioglass PLGA scaffold can be the appropriate choice for the further application on bone tissue engineering as an alternative treatment plan for bone replacement therapy. Lastly, we would like to say thanks to the advisor, stem cell team researcher, and Faculty of Dentistry, Mahidol University for the guidance and support. Thank you for your attention.
Really excellent work, excellent result, also excellent presentation.
Thank you.
May I ask you, how many shades do you perform in the experiment?
You mean the
Number of samples?
or the number of samples? We put in like 2,000 cells per scaffold.
Number of shades. I mean, that you take from the tissue source.
We did only one check.
But you do triplicate.
Yes, but we done triplicate.
Okay. You say that 10 bioglass PLGA is better than 15 because the 15 it has toxicity. How you test the toxicity of BG and why they did not have in 10 BG?
We study more about the property of bioglass, and we found that the bioglass has the hydrophobicity. So being a hydrophobic, the medium cannot like attach, the media cannot go inside the scaffold as well as the 10%. So the cells were less proliferate and less differentiate.
I mean, toxicity is say that 15 BG has toxicity.
We assume that the toxicity is the cause of hydrophobicity, therefore the cells cannot proliferate inside the scaffold.
10 BG, do they have any toxicity?
From our research now, and from the result that I present, the 10% bioglass PLGA is the most optimal one without showing any disadvantage.
Because you cannot conclude.
Okay, thank you very much for your work. It's like a postgraduate level research. Okay, I have a question about the optimal concentration of BG, right? Because you say that no one investigated this before, and you select the test on 10% and 15%, right? How about 5%? Why you skip that that level of percentage?
Because there are research done before me, and I found that 5% cannot make any difference into the PLGA.
You?
And even not I, the stem cells team researcher.
Oh.
And also 20%. 20% is the way we fabricate the scaffold. 20% is too much for the scaffold to construct into the 3D. Because as I mentioned before, bioglass contain bioglass itself is low mechanical strength.
And why 5% BG didn't work well?
We found that it has no difference between like pure PLGA and 5% bioglass PLGA.
Okay.
The result is not different. It's too low.
Okay, you should mention because I question why. Why is 5% no? Why skip to 10%?
Sorry for that misinformation.
Thank you.
I agree with Dr. leadership that your work is very excellent and should be a PhD candidate for. So I want the conclusion that you claim that the benefit of the 10% GDP scaffolds, the choice for application for more tissue engineering. So, but in your methodology is very limitation of the time, just 14 days, only 2 weeks. So, what should you think about the result that extend to 1 year or 2 years?
Actually, we plan to like investigate more on like gene expression or differentiation into osteoblasts for the further like genes, not only like CBFA1 and osteolytic, but due to the time and due to the facility, it limits us only to do like this day. But if I have a chance to do more, I will do it for the better result.
I have one question. Is this real? Is this really?
It's real. It's the same person, but it's not done by the bio tissue engineering. It's not done by bone tissue engineering. It's done by surgery.
Is your friend?
No, it's not my friend. He's the one of the contestants in the Let Me In Thailand. So maybe I think like bone tissue engineering may be like another choice in the future.
Okay, thank you very much. Okay, the next group is Miss Chanya Pethaibu. Okay, in the topics of the study of DNA structure and chondrogenic protein expression in type 2 diabetes animal model.
Good morning, colleagues, ladies and gentlemen.